Hey Rebels, welcome back to Rebelcast, your go-to source for critical appraisals and the latest in knowledge translation of cutting-edge medical research and emergency medicine in critical care. I'm Mark Ramsey, and I'm joined today with my co-host, intensivist and good friend, Frank Lodeserto.
Thanks, Mark. Yeah, I'm a dual-trained adult and pediatric intensivist. I am also an internal medicine program director, so I love talking about evidence-based medicine and really cool educational topics like we have today. So part one, we talked about a study looking at subcutaneous insulin for mild to moderate DKA, also known as the SQUID protocol. If you missed that episode, go back, take a listen. It's worth it.
Yeah, and today we're shifting gears and talking fluids, especially for those with severe DKA. And those severe DKA patients were excluded from the SQUID protocol. So this is a slightly different question that we're asking, is that in those severe DKA patients, what's better, normal saline or Plasma-Lyte? So we're going to dive deep into the SCOPE-DKA trial.
Yeah, Mark, give us a little background about this trial, if you could.
Sure. Fluids are the first line in DKA, and they're a cornerstone of therapy, but there's always been a long-standing debate over which fluid is best. Normal saline sure is everywhere and cheap, but it's high in chloride, and that chloride load can worsen acidosis, which we're going to talk about later. Plasma-Lyte, on the other hand, is a more balanced solution and may resolve the acidosis faster. I personally discovered this when I was an intern. The difference in normal saline and Plasma-Lyte was huge. I was the only resident in my EM program who continuously ordered Plasma-Lyte, and it tended to really piss off the nurses because they had to run to pharmacy to get it. So, Frank, tell us about this study, who did it, and where.
The study was done by Ramanan et al., and it was a cluster crossover open label RCT across 7 Australian ICU. And let's walk through this study design. Mark, could you talk us about this study design, this cluster crossover open label RTC?
Yeah, so with severe DKA patients, they were randomized to receive either Plasma-Lyte or 0.9% saline for all resuscitation and maintenance needs. The sites then crossed over after 6 months to use the alternative fluid. Frank, tell us a little bit about who they included.
Yeah, interesting. They took patients over 16 years of age. In the US, we're taking patients over 18, but they included patients over 16 years of age with severe DKA, moderate to severe DKA, defined by a pH less than 7.25 and a bicarb less than 15, a glucose of 14 millimoles per liter, and if used in our US system, that's about 250 milligrams per deciliter. And these patients were all destined for ICU admission per clinician judgment. They excluded patients less than 16, repeated participants, fluid contraindications, and suspected HHS instead of having DKA as the primary diagnosis.
Yeah, and the primary outcome was a base excess of greater than -3 within 48 hours of ICU admission. They also specifically looked at DKA resolution at 24 hours, which was defined by the ADA criteria as a glucose less than 200 milligrams per deciliter, plus 2 of the following things. Your bicarb was either greater than 15, your pH was greater than 7.3, or your anion gap was less than 12. And so which fluid came out ahead?
Plasma-Lyte came out just ahead. Nothing dramatic, but it nudged forward to give you faster acidosis correction without ketone spikes and no patient safety concerns, which is great. What about other safety issues, Mark?
Yeah, there actually weren't any significant differences in either hypoglycemia, hypokalemia, or even persistent ketosis, just a subtle advantage in the acid-base normalization that occurred. Let's pivot and jump quick into strengths and limitations, Frank.
Yeah, this is interesting. I learned a lot from this study because some residents or physicians may not have Plasma-Lyte at their institution, but Plasma-Lyte contains something called acetate, and I learned this from reading the study that acetate is a precursor for ketone formation. So they're wondering if this can lead to increase in ketones, acetoacetate, which can lead to beta hydroxybutyrate, and does this lead to increase in ketone production with Plasma-Lyte? And also, fluid was the only variable in this study, which is also a strength. Everything else was protocolized.
Yeah, what's interesting about your Plasma-Lyte comment, I want to interject quick, is that for those who don't know what's in what solution, I highly encourage you to go to our Rebel review page where it breaks down the composition of fluid. We break down normal saline, we break down lactated ringers, we break down Plasma-Lyte. It's not only in our Rebel reviews, but you can also check it out on our social media pages as well. So, with that said, there's some interesting strengths and some limitations that they had with this open label design. And this open label design, it does introduce some bias. The volume and rate of fluids was left to clinical discretion. And whenever you have clinical discretion, it can and does deviate a little bit from the study protocol. And I think this information would have been very interesting to find out. Personally, I think it was a missed opportunity, especially since these are the three typical solutions that are most commonly used, at least in the hospitals in the United States.
Yeah, I agree with you there, Mark. Also, something I think that's interesting is they looked at base excess and base deficit. Now, Mark, when you round in the ICU, how often do your residents talk about the base excess and base deficit? I find, at least in my unit, it's often ignored. When they write down the numbers on their blood gas, they never include the base excess, base deficit. And when I talk about it, it's like this mysterious thing. No one knows why it's there or why it exists.
Yeah, we definitely, at least in the medical ICUs I work at, it's not a common thing to hear. One of them is common in my cardiac ICU, which is base deficit, and base excess is almost always reported immediately post cardiac surgery. I think the nurses have come to expect that lab value and they're quickly giving bicarb to replace it. But to your point, no, in a medical ICU, we do not hear these terms very often. And I think it's also a missed learning opportunity for residents to better understand how they can contribute to metabolic acidosis and metabolic alkalosis. So let's jump in. Teach us, Frank. Tell us what you know.
Go too much in depth on this, but a lot of people know how carbon dioxide causes acidosis. People understand bicarb. When it gets to base excess, base deficit, simply put, if you have a base deficit, it's simply telling you have a metabolic acidosis. And if you have a base excess, it's telling you have a metabolic alkalosis. It ignores or it factors out CO2 in this and just tells you simply if you have a metabolic acidosis, base deficit, or a metabolic alkalosis, base excess. And I think we lost this concept when we were in med school. It was so focused on Henderson Hasselbalch, but it really comes back to this Danish physiologist named Sigurd Andersen, who really in the mid 1900s talked a lot about base excess, base deficit, because bicarb and pH and CO2 don't always explain what's going on in acid-base situations. And base deficit, base excess helps us a little bit. So I think that's why this study was done in Australia. They used that as a marker to look at whether DKA corrected or not, rather than simply looking at bicarb, because things can alter your bicarb.
Yeah, and that's a really important point. I mean, when we're talking about correcting DKA, we shouldn't just be looking at the pH or bicarb alone. In fact, in any critically ill patient, we should never be looking at one test in isolation, but rather the whole clinical picture. And so when you factor in that whole clinical picture with additional information like base excess or base deficit, it gives us a more metabolic complete picture of how far off base that patient is doing.
Absolutely. And what I commonly see, or you might also commonly see, and listeners probably commonly see, is the anion gap a lot of these times closes, but they still have a low bicarb level. And then if you look, their chloride's probably elevated. So you're wondering, did this patient correct? The gap's closed, but why are they still acidemic? And I think this comes to an understanding of the strong ion difference. And that's not something, again, I learned in medical school. Mark, we trained in the same fellowship program, and they emphasized the strong ion difference. And that's something the listeners may or may not have heard before. What really the strong ion difference is a way to understand in a little bit more intricate way how acid-base physiology works. We understand carbon dioxide can decrease your pH if your carbon dioxide level is elevated. But this strong ion difference really throws people off a little bit. So what it says basically is bicarb and hydrogens, which are the focus in the Henderson-Hasselbalch method, are really dependent variables. The real drivers of acid-base physiology is sodium, which is your major cation, and chloride, which is your major anion. And the difference between those two, your major cations and anions, is called your strong ion difference. Looking at it this way, the more chloride you have relative to your sodium. So if you have a normal sodium level, high chloride level, people understand that causes acidemia. What that does is narrows your strong ion difference. And what it does, since you have more chloride, an anion with a negative charge, this is going to drive hydrogen production and cause acidosis. The more sodium you have relative to chloride, so it means your SID widens, your strong ion difference widens. That means you have more positively charged cations, and that is going to drive bicarb production and lead to alkalosis.
That's an awesome way to break it down. And I think the important thing to note is the fluid composition of what we're administering to patients. Like we mentioned before, if you're giving sodium chloride, the key players are sodium and chloride, and that you are giving a high sodium and chloride load, right? And that is less physiologic than if you were giving a solution that is more balanced or has a more rounded electrolyte profile, such as Plasma-Lyte.
Yeah. If you're running here, listening in the car, I don't want to throw a lot of math at you, but if you have 154 milliequivalents of sodium and 154 milliequivalents of chloride, there's nothing normal about that at all. I mean, that is going to slightly increase your sodium, but it's going to really raise your chloride level. And if you raise your chloride level, narrow your strong ion difference, it's going to generate more and more hydrogen ions and cause an acidosis. So the cool thing about Plasma-Lyte, and again, some people don't have it at their institution. I currently don't right now, but I have had it in the past. It has 140 milliequivalents of sodium, and it has a lot less chloride, more of a physiologic level, 98. So it has other things like potassium and magnesium, but then it can't be electrically imbalanced, so they have to put something in it. So what they added to it is acetate and gluconate. And what happens with acetate and gluconate is they're metabolized in the liver, they're utilized by the body, but basically you've given a fluid that just has 98 milliequivalents of chloride. So you're not going to raise your chloride level, and it's going to widen your strong ion difference. So it's going to generate more and more bicarb. So it causes more of an alkalizing effect, an alkalemia. So you're not going to see the problems you have with normal saline causing acidemia by raising your chloride. So this can really quickly cause alkalosis and hopefully narrow your gap quicker, like we saw in this study.
Yeah, and this ultimately helps correct that acidosis in DKA patients. And compare that to normal saline. So normal saline has 154 milliequivalents of sodium and 154 milliequivalents of chloride, like we mentioned. So that strong ion difference is 0. And that overwhelms the buffer system and thus worsens the acidosis. So what's interesting about this is I use it as my main teaching point with nursing staff, both in the emergency department and the ICU. When I was an intern, they would often ask me, why are you so hellbent on giving Plasma-Lyte? And I would simply say, why would I want to give normal saline, a solution that worsens acidosis, in a patient that already has diabetic ketoacidosis, right? And it's usually at that point they would quickly understand that, oh yeah, why are we doing that? And then they would proceed to terms that I hate in medicine. Well, this is the way we've always done it. We need to change that culture and do what's best for the patient by giving them something that's a bit more physiologic.
Yeah, absolutely. And just so our listeners, and I don't want to confuse anyone, the insulin is what's shutting off ketosis. But again, as Mark said, we don't want to give this extra chloride load to make the acidosis worse when we're already correcting that ketosis. Why throw this chloride load? Why make them more acidemic? And why confuse ourselves? Gaps closed. Now they're still acidemic. Now we got to add extra fluids or do something else to them. And that could prolong ICU stays. So this is a really nice way, a very physiologic way to correct patients by using a balanced fluid. And if you have LR is a great substitute, but this study didn't look at that. It looked at Plasma-Lyte, which definitely will cause more of an alkalizing effect on the body. Yeah, so great discussion, Mark. Love to talk about strong ion difference more, but let's get this wrapped up too.
Yeah, totally. And it's important to know that it's not just about volume, it's about the ion composition. And for our listeners who are overwhelmed by the numbers, don't fret. Like I said, we have a Rebel review that breaks down the fluids and the composition of their electrolytes in our Rebel review and on our site. So the bottom line is that normal saline can slow your bicarb recovery even after the anion gap is closed.
Absolutely. Just to reiterate what Mark said, just focus on the concept here and why chloride can cause acidemia and understand other fluids can prevent that from happening. So I think that's the bottom line. Hopefully I didn't explode your mind here doing some math and hearing these numbers, but just understand that concept of the strong ion difference.
Yeah, and until we get a phase 3 trial or maybe a 3-arm composition with lactated ringers like you mentioned, the real message is to be aware of your fluid impact on the acid-base balance.
As Mark said, this is a phase 2 trial, just trying to show safety and also trying to show that Does acetate lead to ketosis? And both of those things. It looks like it's safe. It looks like acetate doesn't lead to ketosis. Also, just keep in mind, look at that base excess again on your blood gas. It might be important. Understand the strong ion difference and how fluids can affect that. And have fun running on these tough DKA patients.
Well said. That's all for now. Thanks again for tuning in, Rebel listeners. And be sure to follow us on social media, where we post our Rebel reviews, visuals, and our latest posts. Subscribe to Rebelcast on your favorite podcast medium. And again, head to the website, rebelem.com, for all of the breakdown of papers. Thanks again for joining me, Frank. And again, until next time.